Welcome to the Week 5 lecture. This week we will see how the respiratory system can go wrong. You should have read these 2 chapters by now. Let's get started. The respiratory system allows us to bring in the oxygen we need for aerobic respiration and eliminate the carbon dioxide we build up as a waste product. It consists of the mouth and nose all the way down to the lower lobes of the lung. The lungs sit in the thoracic cavity. Expansion of the diaphragm along with the muscles of the chest wall and back aid in expanding the lungs as the lungs are adhered to the parietal pleura by a thin layer of liquid. The lungs are the main portion of this system. It consists of 3 lobes on the right and 2 on the left. The larynx is most superior with the trachea inferior. The trachea divides the mediastinum, forming the right and left primary bronchi. Bronchioles then come off the bronchi. Since the right bronchus comes off first and is a straighter shot, it is more prone to aspiration, meaning food and other materials entering the lungs. The right lower lobe is the most common point of aspiration pneumonia due to gravity. The mucociliary apparatus is essential to keep the lungs clean. Without it, they will become filled with mucus and debris that will inhibit respiration. Also, infections will run rampant. Remember the pseudostratified epithelial cells from AP1? They are the ones that have the cilia. Smoking damages the system, and this is why smokers have to cough up mucus constantly to keep their lungs clear of mucus and debris. Goblet cells secrete mucus. They are unicellular exocrine glands that make mucus on body surfaces like the lungs or the digestive system and other areas. Always remember the goblet cells make mucus. The bacteria and fungi of the respiratory system live with us in a symbiotic relationship. They only exist in the upper respiratory tract and do help to keep more dangerous pathogens out. The lower respiratory tract is aseptic. If our mucociliary apparatus is damaged, then this can be an area of infection, as areas that lack normal flora are more easily colonized by intruding pathogens. Gas exchange occurs at the alveoli, where hemoglobin picks up oxygen and becomes oxyhemoglobin. Carbon dioxide is expelled from the blood's plasma at the same time. The ability of oxygen to dissociate from hemoglobin depends on temperature and pH. If a person is under hypothermic conditions, then their oxyhemoglobin will have difficulty dissociating from the oxygen it's carrying. Increased pH will also have more difficulties in dissociating oxygen from oxyhemoglobin. The opposite is true with hyperthermia and more acidotic conditions. Again, oxyhemoglobin is oxygen bound to hemoglobin. SaO2 is the percentage of saturation of hemoglobin with oxygen. You can measure this using a pulse oximeter. The pulse ox can see the red blood cells in the capillaries of the fingers, and using light chromatography, it can tell the level of oxygen bound to the hemoglobin of the red blood cells. Erythropoietin, or EPO, as we have discussed in prior lectures, is stimulated by hypoxia. It is made in the kidneys, and when it is released, it stimulates red blood cell production. The diaphragm is an essential muscle for the respiratory cycle. It flattens for inspiration and domes for expiration. It is innervated by the phrenic nerve, which originates at C4, and any spinal injury above this level will result in the patient who must have a ventilator to live, as the diaphragm will no longer function. Muscles used in respiration are not only the diaphragm, but the thoracic muscles like the external and internal intercostals, as well as abdominal muscles like the external and internal obliques and rectus abdominis. The sternocleidomastoid of the neck is also involved, and you can see this when a patient is in respiratory distress, as they really use this muscle to breathe. In inspiration, these muscles help to expand the thoracic cavity, and in doing so, they increase the size of the lungs, because the visceral pleura of the lungs are attached to the parietal pleura of the thoracic cavity by a thin layer of liquid. Expanding the lung space will create a negative pressure or a vacuum. It brings air into the lungs when these muscles relax. The opposite happens, and now you have more air and less space. So a positive pressure is present and exhalation then occurs. Again, inspiration is due to the negative pressure created from making the lung space larger with the same amount of air inside, and expiration is the reverse, where the space is now smaller with more air inside, causing a positive pressure. This is accomplished by enlarging the thoracic cavity through the contraction of the diaphragm and the muscles of the thorax and abdomen, along sometimes with the sternocleidomastoids, which are usually not used unless we are in distress. Ventilation is the air taken into the lungs, and perfusion is the blood flow ready to accept the oxygen and disperse the carbon dioxide. Ideally, this should match, but in the case of, say, a pulmonary embolism, then there will be a wedge-shaped mismatch in the ventilation and perfusion. A VQ scan will show a patient's ventilation and perfusion. Here's a normal one on the right. Breathing is controlled by the medulla oblongata and some input from the pons as well. Changes in CO2, which also alter blood pH, will stimulate breathing if CO2 is high or the blood is acidotic. This will increase respiratory rate to blow off excess CO2. Carbon dioxide will cause respiratory acidosis if it gets too high in the blood, and this is called hypercapnia. If a patient becomes chronically hypercapnic, then oxygen levels will be the primary control of respiratory rate. This is why you never give too much oxygen to a patient with emphysema and chronic hypercapnia. Instead, we allow these patients to be permissibly hypoxic, as too much oxygen will cause them to stop breathing and lead to respiratory failure. All right, now on to the pathologies you've been waiting for. The first signs of lung pathology can be cough or dyspnea, but these are not specific, as they can also be due to the heart, like we saw last week. Is dyspnea more orthopnea, or worse, with movement? Is it accompanied by chest pain, or is there a productive cough with a purulent-looking sputum? Is there hemoptysis present? Hemoptysis is coughing up blood. It can be quite alarming when it happens. Is it from the lung to the GI tract? Could it be tuberculosis? Any patient with hemoptysis must be considered for TB, as this is a very treatable but life-threatening condition. Atelectasis is where the lung sags or collapses on itself, but there is no air in the thorax, so it can quickly expand if cough occurs or a use of an incentive spirometer. Pneumothorax is collapse of the lung from an air entering the thorax, compressing the lung, and a chest tube must be inserted to get the air out before it can expand again. An incentive spirometer is used when patients have had surgery and cannot fully expand their lungs due to pain and being in bed for a time. They are also helpful in patients who have had medical illness that requires long bouts of bed rest. This is the cure essentially for atelectasis, as the lung can easily expand back to its normal size, as there's no air in the thorax like in the pneumothorax. Pneumothorax again is air in the pleural space between the parietal and visceral pleura. It occurs in patients with Marfan syndrome, for example. It can come from trauma as well. In primary spontaneous pneumothorax, there is no trauma. It occurs in men with Marfan syndrome or just tall young men. Secondary is from underlying lung disease like patients with emphysema. Traumatic pneumothorax can be from a forceful blow to the chest wall or due to rib fractures or a penetrating injury to the chest. Treatment is a chest tube with suction, as the wound is still allowing air into the pleural space. With tension, there is air in the pleural space that must be let out. Usually a needle will do this. This pneumothorax happens during a code or in a closed trauma. Iatrogenic is from medical procedures like a thoracentesis. Symptoms of pneumothorax include chest pain, shortness of breath, and increased respiratory rate. Asymmetry of the chest may be seen along with hyperresonance with percussion. Auscultation of the affected side will elicit no breath sounds. Diagnosis is by chest x-ray, sometimes CT scan if it's small. Treatment is chest tube with suction, but if just a tension pneumothorax, it may just need a needle insertion. Hypoxia is the lack of O2 or oxygen in the tissues, while hypoxemia is the lack of oxygen in the blood. A physical examination of the lungs involves inspection of the chest for breathing pattern or chest wall abnormalities. What is the patient's respiratory rate? Look at the fingers. Or do they have clubbing? Is the patient using accessory muscles of respiration like the sternocleidomastoids? With palpation, does the patient have fremitus, meaning increased vibrations with speech? Maybe there's air under the skin from a ruptured emphysematous bleb or overventilation, as they have crepitus. Auscultation of the posterior chest to hear the majority of the lungs, and the anterior chest to hear the right middle lobe and left lingula. The lung sounds will be decreased if there is pneumonia or a pleural effusion present. If there is asthma or COPD, then you may hear inspiratory or expiratory wheezing or both. If emphysema, you'll hear no breath sounds, and the same goes for pneumothorax. Maybe you hear abnormal breath sounds like rowels, which are indicative of pneumonia. Rhonchi, which sound like snores but indicate inflamed bronchi. A friction rub indicates pleural inflammation. Percussion is an important part of a lung exam. If the sounds are dull, then maybe a mass or a fluid like a pleural effusion. If hyperresonance is present, then emphysema or pneumothorax. Before ultrasound, this is how lungs were marked for a thoracentesis to remove a pleural effusion. If you have the patient say words to you while listening to the posterior side, then you may hear the words are louder. If they are louder, then like in bronchophony or agophony, then this could be a pneumonia. Sound travels better in liquid than air, and this is how whales can communicate from such long distances. If the words sound muffled, then it could be a pleural effusion, and this will move the lung away from the chest wall and make the sounds harder to hear. A chest x-ray is a valuable, inexpensive tool to evaluate the chest and lungs. We can see pneumonia or pleural effusions. If the heart is enlarged or normal in size, rib fractures may be identified or masses in the lungs can be seen. Look at the x-ray on the right. It has many of the important structures labeled. The white areas of a chest x-ray contain calcium, as calcium will stop x-ray beams and therefore appears white on the film. Many of the white structures contain blood, and blood has calcium in it. Bone is the whitest part as it contains the most calcium. The black areas are air. The darker the area, the more air it contains. A CT scan of the chest is helpful to diagnose lung disease. The CT scan gives the best picture of the lungs, and with IV contrast, you can diagnose pulmonary emboli. Lung masses can also be diagnosed by CT as well as pulmonary fibrosis. Pulmonary function testing or spirometry will help us see how well a person's lungs function. The key to a good PFT is coaching and making sure the patient is doing the best effort possible. We get several good pieces of information like the FVC or forced vital capacity, or the amount of air that's expiratorily expired after a forced inhalation and then exhalation. The FEV1, or how much air the person can expire in 1 second. The data forms the flow volume loops you see in this report. The total amount of air in your lungs is the total lung capacity. What we use to live is the vital capacity. When you take a normal breath, that is the tidal volume shown in the image. When you do maximal inhalation, then you use the inspiratory reserve volume. Your lungs are capable of much more, however. They hold in so much air that after you exhale in a normal breath, that is the expiratory reserve volume plus the residual volume, which is the functional residual volume. If you really exhaled hard, you could get rid of the expiratory reserve volume to make room for new air. You cannot get rid of the residual volume as it is left behind after maximal exhalation. These are the lung volumes again. The most important volumes you need to know for the exam are the FEV1, or the forced expiratory volume in 1 second, and the forced vital capacity. You need to know what they look like in an obstructive or restrictive lung disease patient. We can assess a patient's oxygenation, pH, and CO2 level from an ABG. It is usually taken from the radial artery in the wrist, but it can be done from any artery. The first patient has a severe metabolic acidosis called lactic acidosis from ischemic bowel, and the second patient has a metabolic alkalosis from severe dehydration and from being found quote unquote down outside. And ABG can give us valuable information and help us with ventilator management. Respiratory failure can occur with many different pulmonary diagnoses. If the respiratory rate is high, the patient is using accessory muscles to breathe, and the oxygenation is low, then this may warrant intubation. Also, if the CO2 level is really high in a patient with emphysema, this may too warrant intubation as they go into hypercapnia and unconsciousness. The ventilator is used to help patients in the respiratory failure to breathe. Patients who can no longer breathe on their own or are in acute distress will be intubated or on an endotracheal tube placed in their mouth and into the trachea. This machine will then regulate their breathing. Here we can regulate the TV or tidal volume, which is the amount of air in each breath, the rate or how fast or slow they breathe, the FiO2 or how much oxygen they are getting, and finally the PEEP or positive end expiratory pressure or how much pressure is used to open the airways or alveoli. This will help keep the airways open in a patient. A bronchoscopy is used to help diagnose lung diseases. Biopsies and cultures can be taken to determine the cause of certain lung diseases. The flexible scope is inserted in the mouth through a bite guard and enters the larynx and trachea. The patient is sedated but not fully unconscious. Acute rhinitis is inflammation of the nasal passages causing a quote-unquote runny nose, usually caused by viruses or allergies. If allergic, then the eosinophils will be elevated. Acute sinusitis is inflammation of the sinuses. You can examine the sinuses by pressing on them, like with maxillary sinuses, or have the patient lean forward to see if they have facial fullness. Acute sinusitis is new sinusitis, and subacute means it has lasted for a bit, or a while. Chronic is long-term sinusitis and usually from allergy. Bacterial sinusitis can last for weeks and must be treated by antibiotics. Nasal steroids are useful for sinusitis only. Chronic sinusitis can be evaluated by a CT scan and usually due to allergies. Acute pharyngitis is inflammation of the pharynx and usually due to viruses. If bacteria are concerned, then group A beta hemolytic strep must be considered, as this can have serious complications if left untreated, as we went over earlier in this course. This bacteria can cause renal failure and other complications. The pharynx will be erythematous on exam and may have purulent material. It may or may not involve the tonsils. The patient will have a very sore throat and usually no cough unless there is a postnasal drainage. Tonsillitis is inflammation of the tonsils and can be from a virus or bacteria. If the tonsils are too large, this can slow recovery, block the airway, and inhibit the ability to eat. Tonsillectomy can be done to remove the enlarged tonsils. Group A beta hemolytic strep will cause tonsillitis if the tonsils are still present and will leave purulent material on them as shown here. Epiglottitis is an emergency and can be seen most times on exam and especially on x-ray, where you can see the classic steeple sign. If the epiglottis gets too large, it can impede the airway and prevent breathing. This will require a tracheotomy, which is performed to open airway into the trachea and bypass the epiglottis and larynx. Laryngitis is usually from a virus and causes loss of voice. Tracheitis is much more severe and can inhibit breathing. Patients with this will have a high-pitched cough. Children with croup will have a barking cough. If laryngotracheitis is and due to bacteria, then it could lead to epiglottitis and the need for a tracheotomy. Acute bronchitis is usually viral in origin, but can be due to bacteria. The patient will have a hacking cough that is usually productive. Smokers will get this very easily. Influenza virus can cause a tracheobronchitis. Other pathogens listed here have been found to cause a bronchitis. Bacterial bronchitis will have a fever and possibly purulent-looking sputum with expectoration. It may take weeks before there's any improvement. Bronchitis can begin with a common cold or sore throat. It can last up to 3 weeks. Some studies have shown sputum color changes to not be very helpful, while others have. If bacterial, then give antibiotics. If viral, then it is usually self-limited. Cough suppressants may be needed at night so the patient can rest. Pertussis is whooping cough, and due to the bacteria Bordetella pertussis, it has a vaccine as it can be dangerous in children. It has made a comeback in recent years. Pneumonia is fluid in the lungs. It can be from viruses, which are most common, or due to bacteria. It is the leading cause of death of all types of infections. It can lead to respiratory failure and intubation if worsens. There are two main types based on the location of the patient at the time of infection: community-acquired pneumonias and hospital-acquired pneumonias. Hospital-acquired pneumonias occur at any time of the hospitalization after 48 hours or so. They can be patients just on the floor or those who are critically ill on ventilators. If on a ventilator and acquired a new pneumonia, then those are ventilator-acquired pneumonias. Most pneumonias are viruses, especially influenza virus, and will pass on their own. But the most common bacterial pneumonias are the typical pneumonias, and less common are the atypical, with the exception of Mycoplasma pneumonia, which is the classic walking pneumonia of young people. Atypical pneumonias can have extrapulmonary features like hyponatremia or GI problems. Immunosuppressed patients like those with AIDS may have pneumocystis jirovecii. Streptococcus pneumoniae is the most common bacterial pneumonia and is a typical pneumonia, meaning it presents like we would expect with fever, productive cough, x-ray showing an opacification like the one here, colored for your convenience. Remember, though, that most typical pneumonias are viruses and not bacteria. The atypical bacterial pneumonias are Mycoplasma pneumoniae, Legionella pneumophila, and Chlamydia pneumoniae. Mycoplasma pneumonia is called walking pneumonia, as the symptoms are usually mild enough that the patient can walk about without issues. Legionnaire's disease can be fatal and comes from water droplets like from air conditioning systems or produce misters. If infection without pneumonia, then it's called Pontiac fever. Hospital-acquired pneumonia is a pneumonia infection from a hospital admission at least 48 hours. As before this, it can be blamed on the community still, as the patient has not been exposed to the hospital long enough. These can be potentially resistant organisms and very dangerous. Ventilator-acquired pneumonias is hospital-acquired, but with patients on a ventilator. This can be very deadly as well, with again very resistant organisms involved. If aspiration happens or food or liquid escapes the epiglottis and enters the lungs, then pneumonitis occurs. If repeated, then an infection can set up from oropharyngeal pathogens. Pneumonia symptoms include coughing, fever, chills, pleuritic chest pain, which is chest pain from breathing in deeply, dyspnea, hemoptysis, tachypnea, using accessory muscles like the sternocleidomastoids, along with exam findings like dullness to percussion, increased vocal sounds like egophony, bronchophony, and whispered pectropiloquy. Patients will have crackles on auscultation as well. Along with a good history and physical examination, look at the vital signs. Get a CBC with differential. Remember, neutrophils fight bacteria. Chest x-ray will help, but many times the x-ray is slower to show the pneumonia if it just started. Get a sputum culture, but it must be a deep and prior to antibiotics. Only treat with antibiotics if it is bacterial. Most viral pneumonias will resolve with supportive care. TB or tuberculosis is a dangerous infection that can lay dormant for years. The bacterial Mycobacterium tuberculosis is the cause. It is easily transmissible and from respiratory droplets. It is an aerobic bacteria and lives in the lungs, but also can travel to other areas of the body. A persistent cough with hemoptysis must be evaluated for TB, but this can also be lung cancer, so that is another reason for a complete workup. Weight loss, anorexia, fever, night sweats, which can also be signs of cancer, are also signs of tuberculosis. TB can have Ghon's focus. and can develop caseous necrosis of the lungs, which look a lot like cheese. Pott's disease is rare, but not uncommon in third world countries. This is a TB infection of the spine and can happen in children or adults. The tuberculin skin test is called the Mannix test. In the Mannix test, a positive response means the individual has been exposed to TB and could be infected. It varies based on the immunological abilities of the individual as shown here on the CDC guidance. People with HIV or cancer only need a small response, while those who have good immune systems and are healthcare workers need a larger response to be positive. Treatment for TB is a long course of antibiotics, so we have to be sure of the diagnosis before giving these medications. They must take for months. Lung abscesses happen mostly with IV drug users who develop infective endocarditis. You can also get them from untreated bacterial pneumonias over a long period of time. They also can develop in patients who are immunocompromised. CT scan will diagnose this, and surgery is needed along with IV antibiotics, usually to treat. Elasticity is how stretchy something is. In the lungs, it's how quick the lung tissue is to recoil back after expanding and how rigid it may be. In the case of restrictive lung disease, it has a high elasticity, and the lung tissue recoils back easily, making it hard to bring in air. Compliance is the opposite of elasticity, and is how the lung relaxes or expands. In obstructive lung disease, there's too much compliance. Obstructive lung disease is a lot like a plastic grocery bag that inflates, but is difficult to get the air out. Obstructive lung disease is when you cannot get air out of the lungs very easily. The air is stuck in place, much like our grocery bag. Restrictive lung disease is when you cannot get the air into the lungs because the lungs are too rigid. They are too elastic, like the large rubber band you saw. Examples of obstructive lung disease are COPD and asthma. Examples of restrictive air disease are interstitial pulmonary fibrosis, sarcoidosis, neuromuscular diseases, etc. When it comes to pulmonary function testing, obstructive lung disease has a low FEV1, or the volume of air that can expire in 1 second. The FEV1 of restrictive lung disease will be normal or high. The FVC, or forced vital capacity, is normal or low in restrictive lung disease, as this is the amount of air expired after maximal inhalation, and restrictive disease has trouble with getting air in. The FVC will be high in obstructive lung disease as air is trapped in lungs, and breath stacking can occur as you take more air in and air stays behind. So the FEV1 FVC ratio will be low in obstructive lung disease, and the numerator of the ratio is low, making the overall value low, while in the restrictive lung disease, the FEV1 FVC ratio will be normal or even high, as the FEV1 is normal and restrictive, and the FVC is low, making the overall value of the ratio normal or high. This is important to know as to discern which disease one is dealing with. Obstructive lung disease consists of asthma and COPD. Asthma is reversible obstructive lung disease, and COPD is irreversible. Asthma is mostly from allergy that causes acute airway inflammation and some chronic inflammation. COPD is from excessive mucus production at first, with the loss of the mucociliary apparatus, and then the lung changes to useless dead space. This all comes from cigarette smoking or exposure to cigarette smoking for a long time. There can be overlap as well if an asthmatic smokes and gets COPD. Asthma is reversible obstructive lung disease, also known as hyperactive airway disease. It can be reversed with the use of a beta agonist like albuterol. The airway will inflame in an asthma attack, and medicines like albuterol will reverse this constriction. Allergy is the primary cause of asthma, although there's some data with secondhand smoke exposure during childhood. Asthmatics start young, as it begins usually in childhood or adolescence. Since allergy is the cause, asthma is IgE mediated along with leukotrienes and histamine. Eosinophils play a role in asthma attacks as well, and we learn they too are involved in allergic reactions. Asthma attacks can be initiated by an allergic response to perfume, smoke, dust, viruses like RSV, and GERD, which causes acid reflux that can enter the trachea and cause an asthma attack. Asthma attacks can be frightening to both the patient and the observer. Asthmatics use rescue inhaler like this albuterol inhaler to reverse the airway constriction. They can have cough, wheezing, chest tightness, and use accessory muscles. Other treatments may be steroids or longer nebulizer treatments if the asthma attack is more severe. Hospitalization also could be needed, as well as mechanical ventilation if severe enough to lead to respiratory failure. Asthma is diagnosed by PFT or pulmonary function testing, also called a spirometer. The FEV1 FEVC ratio will be low, like in other obstructive lung diseases, but there will be reversibility. The ratio will improve with administration of albuterol, thus showing this is asthma and not COPD. Asthma is classified into mild intermittent, mild persistent, moderate persistent, and severe persistent. You must know these four classes of asthma. Know that mild and moderate do not go into the hospital, and that mild does not have daily symptoms, but moderate does. As the asthma worsens, so does the PFT volumes. Severe persistent asthma can lead to status asthmaticus, which is the worst case in asthma and usually requires ventilation. COPD or chronic obstructive pulmonary disease is not reversible. Smoking is the worst thing you can do to your lungs, as smoking over the years will change the lungs. First, you begin to have hypersecretion of mucus as the mucociliary apparatus is less functional. Over time, this will lead to the first stage of COPD called chronic bronchitis. In chronic bronchitis, the patient is a blue bloater at first as they cough continuously, at least 3 months of the year for 2 years. They cough so much they turn cyanotic or blue in those spells. Other than smoking, alpha-1 antitrypsin deficiency can also lead to COPD. This is a genetic disease deficiency of alpha-1 antitrypsin. Emphysema is the last stage of COPD and results in dead space and useless alveoli. These patients cannot get enough oxygen and are called pink puffers, as they are hypercapnic and full of CO2. They do perched lip breathing by habit and look like they are puffing a cigarette without one being there. Comparing chronic bronchitis to emphysema, we see that in early COPD, the coughing will keep air from coming in and causing hypoxia and thus cyanosis. The buildup of mucus is what triggers this cough, as the mucociliary apparatus is not functioning as the patient continues to smoke. Emphysema then comes about as the alveoli die off and dead space takes over, resulting in CO2 retention. Lack of oxygen causes cyanosis, while CO2 retention makes the cheeks pink. Emphysema patients will also get a barrel-shaped chest as the lungs expand and no longer participate in meaningful ventilation. Severe COPD can lead to cor pulmonale, which can cause pulmonary hypertension. This can lead to right-side heart failure, as we discussed last week. COPD can also cause hypercapnia if it is in the emphysema stage, and chronic CO2 retention can worsen. If too much oxygen is administered, so these patients must not get 100% SpO2 or they could stop breathing. To diagnose COPD, you need a good history and physical examination. Have the patient do a questionnaire called the CAT, which will ask about smoking history and coughing frequency. Get CBC, chest x-ray, PFTs, and ABG. An EKG can be done to assess the heart, as COPD can cause some dysrhythmias. Remember, the FEV1 and FEV1 over FVC ratio is low and is not reversible with albuterol. If there is a mix with some asthma, then you may see some reversibility. Bronchiectasis is rare, but can come about from recurrent lung infections with certain pathogens. Bronchioles are irreversibly dilated, and this causes a persistent cough and difficulty in expectorating sputum. This can have some similarity to chronic bronchitis. This leads to an obstructive lung disease-like pattern. Sleep apnea is very common, with obstructive sleep apnea, or OSA, being the most common. It is usually due to obesity, and we diagnose this with a sleep study called a polysomnography. It is treated with CPAP, which forces air into the lungs, like in this patient here using nasal pillows in lieu of the classic face mask. Central sleep apnea, or CSA, is more rare and due to a brain abnormality. It is treated with and diagnosed in much the same way. Many of these patients are Pickwickian, meaning they are obese with a short neck with a large neck circumference. Now on to restrictive lung diseases. The most important one to know is IPF, or idiopathic pulmonary fibrosis. This insidious disease is not well understood, and the cause is unknown. There's not a treatment that works well. CT scan will look like a bee honeycomb. Pleural effusions are fluid around the lung, the pleural space between the parietal and visceral pleura. This fluid can be transudative, like from heart failure, or renal failure, or cirrhosis. It can also be exudative from infection, like an empyema. All new pleural effusions must be worked up with a thoracentesis. Patients will have dyspnea, and exam will show dullness to percussion and decreased breath sounds, as well as decreased vocal resonance as the lung is farther from the chest wall. A thoracentesis is performed with ultrasound now as standard of care. We do this procedure mostly to work up a new pleural effusion which may be due to cancer. This can also be done for pleural effusions which may be purulent or be due to bacterial infection, also called an empyema. Testing in the fluid will include pH, cytology, and culture. This procedure is also done to help those with recurring pleural effusions breathe easier. Pulmonary hypertension, as you recall from last week, will increase afterload on the right ventricle and lead to right-sided heart failure. There are several causes to pulmonary hypertension. It can be primary due to a genetic disease or secondary from another disease effects. It can come from left-sided heart failure, which is one of the major reasons left-sided heart failure leads to right-sided heart failure. It can occur from cor pulmonale and long-term COPD and emphysema. You can get it from recurring pulmonary emboli. It will cause hypoxemia and dyspnea in the patient. Treatment is vasodilators. Interestingly enough, Viagra or sildenafil has been used successfully to treat pulmonary hypertension. Remember, we talked about pulmonary emboli and DVTs in week 3. Clots form in the leg veins, and this is called a deep venous thrombosis, or DVT. They can then travel to the lungs and cause acute hypoxia. Usually the patients have sat around for a long period of time, like on a plane ride, or may have an underlying clawing disorder or smoking while on hormone replacement therapy. It is diagnosed by CT-PE study or CT angiogram, but can also be seen on a VQ scan sometimes for the patients who cannot have IV contrast dye. Pulmonary edema is a restrictive lung disorder, but is usually from left-sided heart failure. Treating the underlying left-sided heart failure will help this condition, so using diuretics to lower the fluid volume and placing the patients on ACE inhibitors, angiotensin receptor blockers, beta blockers will also help this condition over time. Hypersensitivity pneumonitis is inflammation of the lungs due to severe allergy, not to be confused with allergic asthma. This condition over time causes pulmonary fibrosis and a restrictive lung disease. Animal protein dust is usually the initiating event, so bones being grinded by a butcher or hair cutting, creating hair dust, or a zookeeper with exotic animals all making dust can be examples. Occupational lung diseases come from working with various types of dust for long periods of time without respiratory protection. Coal miner's lung or coal miner's pneumoconiosis is the most common. There is also asbestosis, silicosis, berylliosis, or the exposure to beryllium dust. Thoracic cage abnormalities can also cause restrictive lung disease. Decreasing the size of the thoracic cavity will decrease the potential size of the lungs at full inhalation, thus limiting the patient's ability to bring in air. These can be corrected by surgery or orthopedic bracing. ARDS is acute respiratory distress syndrome. Now, your book says adult instead of acute, but most use this terminology. ARDS is deadly. If a patient develops this condition, then they are very highly likely to die. Many diseases and conditions can cause this, including myocardial infarction, sepsis, shock, trauma, acute pancreatitis, aspiration pneumonia, and others. It has been associated with COVID-19 infections, causing much of the mortality from this virus. There is no cure. Patients with this condition require 100% FiO2 on the ventilator, and even with a tracheotomy placement, they never get off the vent. Let's review for the quiz and exam. A 26-year-old male presents with wheezing and shortness of breath to an urgent care center. He has no smoking history and denies chest pain. He is administered a nebulizer treatment of albuterol, which is a beta agonist, and his wheezing symptom improves significantly. What is the likely diagnosis? What is your answer? The answer is asthma, as this is reversible obstructive lung disease. The patient is young, wheezing, and gets better with albuterol treatment. A 55-year-old male presents with complaints of daytime somnolence. His wife complains that he snores. On exam, he is obese and has a short neck with a large circumference. What would be the next step in his evaluation? What is your answer here? Polysomnography. The answer is a sleep study. The patient is at risk for obstructive sleep apnea. A 68-year-old female presents with coughing for 3 months out of the past year with a productive sputum. She also gets short of breath when she coughs. States that her husband says she turns blue. She has smoked for 40 pack years and does not plan on quitting anytime soon. On exam, she has wheezing and clubbing of her fingers. Chest X-ray is relatively normal. PFTs show decreased FEV1 FEVC ratio, which did not improve with albuterol. What is the likely diagnosis? What is your answer here? The answer is chronic bronchitis. It is not asthma. It is not reversible. It is not IPF, as this is clearly an obstructive lung disease due to smoking. It is not emphysema, since there is still wheezing and no changes on the chest X-ray, and she is a blue bloater by history, so chronic bronchitis fits this diagnosis best. Which patient below would most likely develop hypersensitivity pneumonitis? What is your answer? The answer is the butcher, as they are exposed to animal protein dust from grinding bones. This is the initiator to hypersensitivity pneumonitis. This is the end of the week 5 lecture. Now let's get out of here.